Welcome everybody to this ISQua ICoHN coffee break. I hope you all have a cup of coffee or tea and are in a relaxed setting. We've been looking very much forward to this coffee break. We are speaking to you from Lausanne in Switzerland. My name is Christian von Plessen. I'm a pulmonologist and quality improver. And we have Tina Foster.
I'm speaking to you from Vermont and in the United States, and I'm an OBGYN and also interested in improvement.
And Catriona.
Greetings, I'm currently in Donegal in Ireland, the northwest of Ireland, in a very mountainous and wet, windy day. And I work with ISQua in the education department, and I will be in Brisbane soon too, so I might see many of you there. And yeah, delighted to be here, and thank you all for taking the time to join us today.
Great. So the title of our coffee break, or what we will discuss, is the power of co-production. Let me share a couple of slides. So what we're going to do after these short introductions, we'll present a bit of theory about co-production, what co-production is. Then we'll have discussions. Let's see how many we will be, but up to 25, I think we can have them all together. Otherwise, we'll break down into breakout groups. And this discussion will be about what co-production is and why it is important for quality improvement. We can discuss questions, and then we'd like to present you some resources for further reading, connecting, and also sessions that will be held at the ISQua Brisbane conference. So I see there's somebody in the waiting room. Yeah, that is good. So we'll kick it off with just a little interactive part on which country are you from, and we're going to use the whiteboard. I'll share that with you. And on the whiteboard,
many of you shared in the chat, but we encourage you to make a little sticky note and tell us.
Yeah.
Whiteboard.
So on the left side, when you scroll down in the toolbox, there is the possibility to add a sticky note. So please write which country you're from. So this is fantastic.
This is also an inaugural ISQua experience with the whiteboard. So
absolutely.
All right.
Isn't it amazing? Okay,
we'll
come back
okay.
to yeah. Yes, we're coming back to the whiteboard for further questions. So before we talk, so just tell us what you're doing, just your professional role. Put it in the chat this time.
Quality and patient safety consultant.
Thank you. Consultancy director, organizational development. Very good. Thank you. We have to get a feel for you so we can connect. I'm a bit nervous. Oh, don't worry.
Oh, sure. Don't worry, we are too.
So we are too with all these technological things. Pharmacist, team lead hepatitis B, advocacy initiative. Interesting.
So great mix of clinicians and administrators and people in patient safety and other roles. Wonderful.
Okay, we'll move to the next question. So we would like to hear from you 1 to 3 words. So what's your idea of co-production? What does it mean for you? Put it in the chat again.
To co-create.
Yeah, so that's Andrea. Andrea, you were in, is that in Chile? Am I right, or in Spain? No, Chile.
Yes, I'm from Chile.
Yeah, thank you.
Interdependent co-workers.
Yeah.
Engagement with patients, co-creation.
Yeah. Integration, interesting.
Working with someone to produce a service, to create something new collectively. You all are great. I think we're going to have some really good discussions.
Mhm. Just take a sip of my coffee. Okay, thank you very much. So, involve patient and provider. Interesting.
Involve patients in decisions.
Yeah. Okay, we'll have more time to discuss this in our discussion part. Unison of purpose. That's beautiful. Well, we can see that, yes, we have experienced good co-production, and no, we haven't experienced good co-production, and some have experienced and not experienced. So there is an experience of this and an understanding. So we just want to bring in a bit of background theory, and I'll hand it over to Tina for that.
Okay, great. So this is from an article that was published in a supplement that we'll talk a little bit about at the end of the talk. And this was really Paul Batalden, who is here on the call with us, really sort of approach to thinking about this. And we bring this in just to connect the idea of co-production to the idea of quality, which is really, you are all here because you're members of ISQua, which is a quality society. And to look back and reflect on the fact that the beginning of the movement towards quality in healthcare was really centered around the idea of how do we know kind of what the minimum standards are for good quality care. So we aren't actually harming people. And yes, we do still harm people, but we have a much better way to approach understanding these thresholds, sort of standards and certification and accreditation. And these are all continue to be incredibly important. As we moved into the 80s, 90s, 2000s, there was an interest in thinking about how we might learn from other industries, if you will, how to actually improve care. So it's no longer enough just to be above the threshold, but how can we actually get much better than we were before? And this led to a lot of work around understanding systems and processes, sort of thinking about customers and suppliers and measurement. How do we know how we're doing? And that has really been the main focus of quality improvement, I would say, for the last 30 years or so. And where we are now is at the beginning of an era where we're actually asking a very different question, which is how might we improve the value of the contribution that healthcare service makes to health? And so we're now focused not on the system per se, we're really trying to understand what we're doing to improve health and well-being for everyone. And this begins to get at the importance of co-production, because when we begin to think about health, we realize that, as Paul, who is here with us, often says, you cannot outsource your health. So what we need to do is understand how to better provide the service of healthcare, recognize who actually owns health, acknowledge the kinship, the relationships that are important between everybody, as people said, sort of the team, the group that is working together to co-produce care, and the need to think about how multiple knowledge systems can be integrated. So it's really quite a different question, and one I think that we cannot answer if we are not authentically working together as health professionals and the people who benefit, hopefully, from the services that we provide. So next slide. I don't know if you can hear the geese flying overhead here, but so this is a lovely picture that I borrowed from Paul's daughter, Maren, that sort of gets to the sort of fundamental question. And we begin to talk about co-production. It's very important that we differentiate between a good, which is a thing that is made and then sold or given, and a service. And I think the important things to remember here are that a service is sort of simultaneously produced and consumed, and a service requires two parties. I can't be a teacher if there are no students. I can't be a nurse if I don't have a patient to care for, and I'm not going to be a student if there's no teacher there. So this is something that happens as a sort of a live exchange between those two parties, the service producer or creator and the service user, as opposed to a good. And I think many of us, certainly here in the US, we have seen a tremendous commoditization of healthcare, where we are trying to sell people a product instead of understanding that what we're really doing is creating a service. Next slide. So this is an example from Sarah Regare, who is a patient in Sweden with Parkinson's disease, who has made this wonderful infographic basically saying, here's how much time I spend managing my health. Here's how much time I am invested in that, right? 8,765 hours in self-care per year, whereas she may see her neurologist for 1 hour. So the tremendous contrast, as we often sit in the world of healthcare and think, gosh, we're doing all this stuff for people. They're actually doing everything themselves. And what we need to do and recognize is the knowledge, the expertise, and the ability that our patients bring to healthcare, and to invite those into our interactions. And I think that is a place where there's a lot of work to do. Next slide. This is a slide that we've stolen from Paul, really looking at sort of the history of co-production and the idea of services, sort of what's different about a service than a product, which was really promulgated by Victor Fuchs, who, when Paul called him up to ask him about this, the example he gave, interestingly, was a healthcare one about the decision whether or not his son needed to go to the emergency room to get stitches for a cut. And the fact that that decision, that service, required both the physician's expertise on the phone and the mom's expertise in describing the situation and knowing the actual event. Eleanor Ostrom won the Nobel Prize and was very involved with understanding the co-production of public services and how citizens actually can contribute to the design, the development, the delivery of a service. And I think what we find is that there's a very rich literature around the co-production of public services, less so in the world of healthcare, where we are just sort of waking up to the fact that what we are really doing is co-producing a service. And I personally am of the belief that services are obligatorily co-produced. Both parties have to be there. The service is all, the co-production is always happening. It's just that we often don't do it very well. Next slide. This again, thank you, Paul, is a really beautiful depiction, I think, of what a service is about. And gets to some of the reasons why co-production is so important. Services involve a relationship between the parties and actions. And there are certain things that we need to be able to do in order to provide or co-produce a good service. So on the relationship side, we have to trust each other. We have to respect each other. We have to be kind to each other, and we have to tell the truth. And I think for many of us, that is, those are essential components, say, when we seek a healthcare service. And I think, unfortunately, many of us have stories about when one of those components was not met. In terms of the actions that are taken have to make sense, both for the person who is benefiting from the service, as well as the person who is helping them co-produce that service. So it has to make sense for who you are, where you are, has to be timely, has to be reliant on science, the best possible evidence that we might have. It shouldn't be wasteful. And as we know from all of our work on improvement over all these years, we need to constantly be evaluating what we're doing so that the science and the actions that we take will keep up with where we need to be. And that's very difficult to do if we don't have a shared set of skills and habits and knowledge about what goes into this co-creation. And very importantly, I think in the world of healthcare, we need to be willing to both share power. Power is usually on the side of the professional. We need to cede some of that. We need to share that with the patient who is bringing their own tremendous knowledge and expertise. And both parties have to be willing to be vulnerable. I think patients are very vulnerable oftentimes when they come for healthcare services. We as professionals need to be vulnerable and willing to admit that we may not know everything. We may not have the best answer. And we have to be engaged. Power is there lurking in that yellow circle at the bottom because it is so important. And ideally, all of this happens within a system that has benefited from design science to design ways to support these activities, a context that is supportive, and where both parties, where there is agency, so people are able to act. So I just find this a really beautiful encapsulation of both the potential and the power of co-production, as well as the very real challenges that get in the way of good co-production. Next slide. This is from the article that Paul's daughter Maren first authored with Paul and many others. And this is looking a little bit more at the idea of co-production within a larger society context. And so the idea that we have a community that we're in, we may have a healthcare system that we're working in. As patients and professionals, we have lives within that system and outside that system. And together, what we're hoping to do is co-produce high-value healthcare service, which will lead to good health for all. There is a big contribution to health from what's happening in the society. We know a lot about the social determinants of health. So we have a responsibility to be thinking about those. And this image also sort of highlights the fact that there are different levels of co-production. And so we may not be able to dive immediately into co-execution or co-delivery of healthcare, but we certainly can all begin to work on civil discourse and how we have those respectful and honest conversations. We may be able to move into co-planning and ultimately into co-execution and co-delivery. Next slide. And this is an example of sort of thinking about that really at an organizational level, and the idea that there is this sort of spectrum for the levels of patient engagement. And I expect all of us in our different locations and setting and contexts are in different places where maybe we in the direct care area, for example, we might give somebody some advice. We might, as a next level, actually ask about their preferences and engage in some shared decision-making. Or we may actually partner in making those decisions. And similarly, at an organization, we might survey patients, or on the other level, we actually might invite patients to co-lead important safety and quality efforts that we're conducting in our organization. Same holds true in the world of policy. We may be doing focus groups, or we may actually have many citizens or patients as representatives on agency committees. So I think this is very broad, and that wherever we are, there's probably a place to start working. Next slide. And so as we've focused here a little bit on sort of what happens in the clinical setting, but obviously we can also co-produce quality improvement. Christian will tell us a story about that. Co-produce research, and there certainly is much more of a call for authentic patient engagement in the design and conduct of research. We can co-produce management, social services, we can co-produce evaluation. So I think the idea that really whatever realm you're in, whether as a clinician or a researcher or an administrator, there are opportunities to think about what co-production means for all of us. So Christian, I think I'll turn it over to you.
Thank you, Tina. Still visitors coming in, participants coming in. So welcome to everybody who's joined in the last minutes.
And the good thing is you're here in time to join in our breakout discussions, which will be the best part of the meeting, I'm sure.
That's it. So, well, think of your coffee or tea and relax. I think, Tina, I'll jump over my little story and keep it for the end, because I think it would be interesting and perhaps required now to go into groups. So I'll just jump over my little story here. So, Catriona, we have 36 participants. Could we break into groups of 6? Yes, so just wait before you do this. So groups of 6, and you'll have 15 minutes. So now it's 16:28. So let's say we meet again 1:45. Would that be okay? Yeah.
Yes.
And we've got some questions for you that you will be able to see in the breakout rooms. Pick one and have a little discussion and think about bringing something back to our shared discussion when we join again. So first question, when have you experienced the co-production of healthcare? So as we saw, some of you have, some haven't, some have, and some have not. You can also think of co-production of research, for example, or quality improvement or policy making. The second question, how are relationships important to health? And is this actually new knowledge? And then the last, how is service making different from product making? So I let you choose the question you want. For the groups, try to go right at it. you might just say your name and role and then jump to the question. There is really just 12 to 15 minutes to discuss. So please, Katriona, could you try to create groups?
And don't be afraid to share your stories. I think stories are powerful ways to understand these issues.
Hi there. So welcome back, everybody. We have some time to discuss what we talked about in the groups. We also want to share with you some resources. This is just also to tell you that the presentation with the slides will be shared. And so you can access the different resources also through the presentation. Okay, let's hear from the groups. Who wants to kick it off? What about you, Andrea?
Okay, I was just going to say I'll do it.
There you go.
No problem. Okay. Well, we discussed. We have a super, and I'm super happy that we spoke a lot of different issues with different ones for different parts, and the important points that I can go with this conversation is that how important is to hear the patient view of what he's going, because sometimes patients feel like as obvious in a different level as the health worker. Mm-hmm. And also how important is to have this integrated conversation between professionals of different interdisciplines. And I was telling my point of view about what happened post-pandemic is that mental health has been really hitting us a lot. And how important is to integrate this in medicine and how these different pathologies influence the state of health of the person, and also how these integrate with dental service. Mm-hmm. Most of people think that, and I was saying that losing a tooth is not a big deal, but it's a deal in your mental health state, and it's a deal in your health normal state. So we were talking about that and how difficult sometimes is to integrate this different to have this communication to go to the final objective that is the patient.
Great. Thank you. Thank you for these insightful observations. Very interesting. Shall we hear, I don't know, Nene, would you like to share your comment here on product making, the specific need, what you put in the chat?
Okay, thank you. Can you hear me?
Yes.
Okay, so I was saying that, you know, in making a product, products generally you think about a specific need, right? And create a product to meet that need. And most likely the product serves to meet that need. So if let's say basic, if a car is created, a car is developed to meet the need of ease of mobility, okay? But when it comes to service making, even though it's developed to meet a particular need, most times it doesn't just, other needs, you know, it would arise. So it becomes more multifaceted than just product making. Product making can be streamlined, direct, but when it comes to service making, so if you create, for example, service of, what service can we talk about now? I'm trying to think of basics, but yeah, every service would not just meet that single need. Other needs would arise that the service would also need to attend to. Now, the service provider may not be able to meet that particular need, but may not be able to meet the needs that arise from their major service delivery, but they would have to consider ways to meet those other extraneous services that come up.
Well, thank you. Well, just one comment. I mean, as you say, I mean, so this can sound like kind of a web of needs coming up and needs coming up, but what also might come up is a web of resources that the service provider can connect to. So I think it can go both ways. Okay, we can hear one more group. Who wants to jump in?
If I may.
Yeah?
If I may.
Yes, please, say your name. I can't see you all.
My name is ICoHN Hirata from Tokyo, Japan. So
Hello.
we talk about a little bit about the service. If we think about the health service, healthcare as a service, so it will be generally be the recipient of the service who evaluate the service, not the provider. And then from the patient's point of view, even the patient doesn't know the details of the medical care. My sense is that the ultimate criteria for evaluation would be how he or she was treated as a person with dignity or something like that.
Well, thank you for that comment. Let me just.
Paul, did you have your hand up?
Yeah.
Well, I can tell about our group, Hamid and Purnima and Katrona and I were talking about the experiences we had in co-production, and Hamid was describing the importance of experiencing the different roles that are involved in making the service. And when you have experience as a patient, even though in this other situation you may be a professional person, you have the benefit of that knowledge. Katrina was saying that there was this very different kind of service experience with the birth of her first and the birth of her second child, and that difference in her experience actually made a very different kind of service possible. The first one wasn't so good, and the second one was much better. And Purnima was describing about the different roles that administrators and clinicians play and the languages that they have to use to do their role sometimes forces them to make a bridge between these different roles and persons. And I was describing a time when I went for a general medical exam after my earlier doctor retired, and I was treated as a category. And then I went to a second general exam and I was treated as a person. And so there was a very different relationship and very different experience. And I was much more interested in doing what the second person was inviting me to consider. And so we didn't get so far in the other questions, but we had I think a good sharing of that different set of experiences.
Yeah, we figured there 3 questions was too many, but people could pick. So we are right at the top of the hour. We're certainly happy to stay on for a minute and just briefly talk a little bit about some of the resources as people can stay, if that's okay, Katrina, but we also understand people may need to leave, and the presentation and slides will be available if you want to come back and look at them later.
Yes. So people are still staying.
Yeah, so.
Happy to. Okay, some people are
Okay.
leaving. So I can just, should I just show the slides?
Yeah,
I think that would
let's
be
do
good.
that. Thank you for being here, Samir.
So for those who are staying, so we've compiled for you some foundation papers about co-production. So that's the first. Then some thematic papers that were published in a supplement in the ISQua journal. And then there is quite a new resource called The Power of Co-Production, like this coffee breaks. So it's 14 podcasts hosted by Paul Batalden, with transcripts in English that you can put into Google Translate and then also translate to other languages. And you find them here on the webpage of icon.org, where you find the podcasts. And they are available on all the normal kind of usual podcast sites. If some of you will go to Brisbane to the ISQua conference, there is a co-production track. So the learning journey was a beginner session, a workshop on how to teach and learn to co-produce, and one also about research. There's also a plenary on the Thursday, which looks at co-production during the pandemic, the COVID pandemic. And then there's another workshop also on the Wednesday. So a lot of sessions in co-production. And the last thing I want to mention is that we will have a podcast corner at the ISQua conference also, where you can listen to podcasts, and then we have people there who you can discuss with.
Yes.
So
Kristen,
this
I
is
would
what we
love
call
to-
Kappa co-production.
And we'd love to meet you in person if you happen to be there. So please come say hi if you're able to go to the meeting.
So I'll end with a citation from Deming, who said, "The consumer is the most important part of the production line." So with those words, I thank you very much.